Hi everybody, this is the last of the slides, and I don't know why. Oh, there we go. Wasn't working there for a moment. So I know you've talked a little bit about this already in lab. This is just a follow-up. What I want you to remember though is what you talked about in class last week, which has to do with the nervous system as it relates to muscles, and as well, you remember you had two things. You had a Golgi tendon organ and you had a muscle spindle. So ask yourself the following. First off, what stimulates the muscle spindle? Is it length or is it stretch? And what does the muscle spindle do? Does it cause the muscle to contract or does it cause the muscle to relax? I want you to think about the same thing with the Golgi tendon organ. Does it get stimulated with muscle length or muscle tension? And what does it do? Does it relax the muscle or does it contract the muscle? Part of what proprioceptive neuromuscular facilitation does is utilize these nervous system processes to the advantage to create an ability to lengthen muscle and therefore causing deformation or stretch and making a change so that that the structures are in a new position, and if they wear shortened, it does help lengthen them so you get increased range of motion and therefore you get increased function. So PNF is also known as active stretching or facilitative stretching. This form of stretching integrates active muscle contractions into stretching maneuvers to either inhibit a muscle or to facilitate a muscle's activation. One thing we must remember in going forward, we have to remember that when a muscle is contracted, its antagonist is relaxed, and also a muscle cannot contract directly after an initial contraction. So kind of keep those in mind. This increases the muscle's ability to remain as relaxed as possible as it's being stretched. So what we're trying to do with PNF is to get the muscle into a very relaxed state, and then within that relaxed state, then we will lengthen that muscle. Reflexive relaxation occurs during the stretching maneuvers as a result of autogenic or reciprocal inhibition. If you remember my previous slides, reflexive relaxation is the ability of the muscle to relax, which therefore allows in lengthening. Inhibition leads to decreased tension in muscle fibers and therefore decreased resistance to elongation. So that is the traditional theory of how PNF started and was created. Although we do believe that's the traditional theory, it's now believed that there is more involved than just this elongation because of decrease in muscle tension. There are also mechanisms of sensory motor processing along with what are called viscoelastic adaptations. So this is the connective tissues within the muscles and its structures that allows adaptation through that tissue of the muscle tendon unit and an increase in patient tolerance. So it does allow, PNF also seems to allow the patient to tolerate the lengthening much better. So we can see here a couple things we need to recognize. If we start here with looking at this diagram, we look at number one and it says the muscle contraction or stretch increases tension by tendons, or two tendons. And of course, if it's tension is measured by the Golgi tendon organ. So we get increased tension. The Golgi tendon organ is stimulated by that tension change, and it sends a message. So number two is muscle contraction stimulates sensory nerve signals that travel to the central nervous system on what are called type 1B fibers. So this is a sensory neuron or nerve that's leaving where the Golgi tendon organ is and traveling to the spinal column to enter into the spinal cord. We then have this message that's being sent from the Golgi tendon organ along and back to the spinal cord, where we have these sensory neurons that have received the message from the Golgi tendon organ. They send their message to what is called an interneuron. And you can see that there are two parts here to the spine. We have the posterior part and we have the anterior part. So the interneuron takes the message from the sensory neuron and travels it anteriorly to speak to the anterior nerves. So Golgi tendon organ recognizes the increase in tension, sends the message along the sensory neuron to the spinal column, where interneurons take that message and take it from one part of the spinal cord to the other. When we see a green plus, it's excitatory. So at this point, the message from the Golgi tendon organ has excited 2 interneurons. So they are now sending a message. Once they get there, two things happens. One of the interneurons sends an excitatory message, and another neuron sends a inhibitory message. So let's follow the excitatory first. So again, Golgi tendon organ, message travels along the sensory nerve to the spinal cord. The interneuron takes it from one part of the spinal cord to the other, and it excites one of the motor neurons. So the excitatory message travels along the motor neuron, which is an alpha motor neuron, and goes all the way down and goes to the stimulating the antagonist muscle, okay? The antagonist muscle to contract. So when we have that excitatory neuron go, which is the light pink that we see here, it causes, in this case, we're comparing quadriceps to hamstrings, the interneuron is stimulated at an alpha motor neuron, and this causes the antagonist to contract, and therefore we get reciprocal activation. On the other side, we can see, again, the Golgi tendon organ measures the tension increase, sends a message along the sensory neuron to the spinal cord. We have an interneuron that takes it from one place in the spinal cord to another, and the other one is an inhibitory message. So the inhibitory message goes all the way down to the antagonist, to the hamstring, and that's the quadriceps, to relax. So we can see that we have the hamstrings contracting, and we have the quadriceps relaxing. So in 5A, we're following along here, the A, we have the muscle relax, and therefore there's decreased tension in the muscle. So this is what's happening when I say that, in order to have normal range of motion, if we think of a biceps curl, if we're contracting the biceps to do an arm curl, then there's also an inhibitory message being sent to the triceps, which inhibits that muscle's ability to contract, and then it allows for shortening of the biceps muscle. Right? Now, in different ways, so we take walking, for example. When we step forward, there is, again, muscles that are contracting, which allows that foot to swing forward at heel strike. Now, at heel strike, we go from heel strike to foot flat. In other words, your foot gets flat on the floor. There is a message that does cause the muscle in the anterior part of the lower leg to eccentrically contract to allow the foot not to flop. But we won't worry about that so much. I'm just giving you an example of how it can work in a slightly different way. For our purposes right now, the Golgi tendon organ measures the tension, sends a message around the sensory neuron to the spinal cord. We have interneurons that are stimulated, which send the message to other parts of the spinal cord. One message is excitatory, to have the hamstring contract, and the other is to be inhibitory, which has its antagonist, in this case the quadriceps, to relax. So with that in mind, we are going to think about that when we're looking at the different types of PNF stretching. And I'm sure you've taken this already in lab. There are 3 types. There is the hold, relax, or contract, relax form. There is the agonist contraction, which I'll spend some time on because I know students get very confused by it. And there is the hold, relax with agonist contraction, which is a combination of the 2. When we looked at the initial parts of PNF stretching, we used to have them performed with combined muscle groups acting in diagonal patterns. We don't generally tend to do that anymore. They have now been modified to stretching in a single plane or opposite the line of pull of a specific muscle group. Of course, what's important to understand is if you're going to perform PNF, your patient absolutely has to have normal innervation and voluntary control of either the shortened muscle or the muscle on the opposite side of the joint or its antagonist. So if a person's had a stroke, for example, and there's no appropriate innervation to muscles, we don't do PNF. This modality is designed for use on contractile structures, not non-contractile connective tissues. So because we're utilizing this pattern here that we saw happening here using the nervous system, this is where we absolutely are needing contractile structures. PNF is more effective when muscle spasm limits motion rather than contractures. And as I said here, it's less effective for stretching long-standing fibrotic contractures. Okay, so with all that in mind, let's have a look at, I'm having real problems here with this today. I don't really know why. There we go. Let's look at hold, relax, and contract, relax first. So we have to remember, as I said previously in the stretching slides, the standard for stretching is holding statically the stretch for 30 seconds. So we want to do that. So you're going to hear me say this quite a few times. We identify the target muscle. So what muscle is the problem, right? Through our muscle testing and our range of motion testing, we identify a particular muscle that is the problem that is limiting the range of motion. So the range limiting target muscle, the muscle that you've decided is the problem, is first lengthened to the point of tissue resistance or to the point of patient comfort, and like any other stretch is held for 30 seconds. Once we hold for 30 seconds, we back off just a wee bit. So in other words, we shorten the muscle. So of course, when we're stretching, we're lengthening the muscle. So in this case, after the 30 seconds, we slightly shorten the muscle. The patient then performs a pre-stretch end range isometric contraction. So they isometrically contract the target muscle for 5 to 10 seconds. So we've lengthened it, we've slightly shortened it, and we ask the patient to isometrically contract it for 5 to 10 seconds. Once that is done, it is followed by a voluntary relaxation of that range limiting target muscle. You've lengthened it, held it for 30 seconds, slightly shortened it. The patient holds an isometric contraction for 5 to 10 seconds. And then you have this voluntary relaxation occurs. And at that point, you, the therapist, passively move that target muscle into a new range as the range limiting muscle is elongated for 10 seconds. Okay? The agonist can be actively contracted to assist in the stretch. So we are trying to contract the muscle, have it relax, and then we passively move it. We continue doing this, right? We take the new range, we shorten it up, we have them isometrically contract, and we passively move it again. And then we hold it for a bit, and then we shorten it slightly, have them contract and continue on. We continue doing this until there's no change in elongation. So we continue doing the process until we no longer find any more lengthening. Once we're finished with the lengthening, we hold that new position of that target muscle. So now it's in a new elongated position. We hold it for 30 seconds in that final position and we're done. The patient does not need to perform maximal isometric contraction. So it doesn't have to be 100% of contraction. I don't know what you're taking in lab, but 50 to 70% is kind of the normal, and then you're good to go. So they don't have to do it. The other thing is patients will tend to hold their breath when they're isometrically contracting. Please ensure that the patient is breathing regularly throughout the process. Now, this is the one where everybody struggles because it's called agonist contraction. Let's think about what happens when we are looking at a muscle and defining agonist and antagonist, okay? So let's go back here to the diagram. So we're going to identify a target muscle. Okay, so in this case, I'm going to just draw a bit of an arm here, right? Okay, and then we're going to just do a bit of a forearm muscle, bone here. I'm not going to worry about drawing the hand at all. Okay, we're going to change colors here. We're going to draw in two muscles here. So actually, just a second, let me just draw in a bit of a part of the scapula here. All right, like so. You know, it doesn't look like a scapula, but it's close enough. So we're going to draw the muscles in. So we're going to go from here to here. Okay, there's our bicep. And then we're going to draw in our tricep here. So again, same idea. Yes, it's not going to be perfect, but this is all about getting the idea of things here. I'll just draw some lines in here that represent the muscles themselves. Okay, so here we have our tricep here, and here we have our bicep here. All right, so we have determined in our testing that the problem muscle is biceps. Okay, so that means that is our target muscle. All right, this is the problem muscle. So let's go back to our slide for a moment here. The term agonist refers to the muscle opposite the range-limiting target muscle. The antagonist refers to the range-limiting muscle. The short muscle, the antagonist, is preventing the full movement of the prime mover, the agonist. The patient concentrically contracts or shortens the muscle opposite the range-limiting muscle and then holds the end range position for at least several seconds. So what the heck are we talking about here? The first thing to understand that we have to find our targeting muscle. This is what's important to understand. That means that our bicep is our targeting muscle, which means the tricep becomes the agonist. Okay, if we go back here in the slides, all the way back here, remember that when a message gets sent, in this case, hamstrings, in this picture, we stimulate the hamstrings to contract, and the quadriceps were inhibited and therefore relaxed. Okay, so we have to keep that in mind when we're thinking about this. So when we're looking here at the diagram, you can see we've defined that our target muscle is biceps and our triceps becomes the agonist. So if the biceps is short, which we've determined, what is going to happen to biceps when the agonist, the tricep, is contracted? So our bicep was our target muscle that was short, and therefore what we want to do, utilizing that nervous system process of that relaxation inhibition reflex, we're going to have the patient contract their tricep, therefore relaxing the bicep, which allows it to lengthen. So this is what's happening when we do agonist contract. The key points are: define your target muscle and have its opposite muscle contract. And because the opposite muscle is contracting, it becomes the agonist. So biceps is the problem. We contract the triceps, which relaxes the biceps. And because it's relaxed, it helps to lengthen it. So the antagonist refers to the range-limiting muscle. The short muscle, the antagonist, prevents the full movement of the prime mover, the agonist. The patient concentrically contracts or shortens the muscle opposite the range-limiting muscle. So in the case of the diagram you saw you would have your patient contract their triceps. And so the patient would concentrically contract the tricep, therefore increasing the range. So the tricep is the agonist because we identified the bicep as the problem. So we say the patient concentrically contracts the muscle opposite the range-limiting muscle, then holds the end range position for at least several seconds. This movement is controlled independently by the patient and is deliberate and slow, not ballistic. In most cases, this is performed without the addition of resistance. So you don't do anything. You identify the muscle that's the problem. You tell the patient which contraction you have the patient do. You're going to tell them which muscle you want because you know the opposite to the muscle that you've identified as the range-limiting target muscle. And you have the patient repeat these contractions until there's no more gains, And of course, you want to rest between the repetitions to avoid cramping. Okay, so the last one is, we'll continue with agonist contraction here. So of course, when we look at this happening, it is especially effective when the significant muscle guarding restricts muscle lengthening and joint movement. So if the patient, if we go back to the bicep-tricep thing I was talking about, if biceps is spasming and really sore and it's hard for the patient to contract or have you lengthen it with resistance, then I'm going to use agonist contraction so that we're going to use the opposite muscle to contract, which relaxes that problem muscle that's spasming and so forth to lengthen it. It's also effective when a patient cannot generate strong pain-free contraction of the range-limiting muscle. Okay, so if you tried hold, relax, contract, relax, and they just weren't able to do it, then of course you would go to agonist contraction. This is very useful for initiating neuromuscular control in the newly gained range to reestablish dynamic flexibility. It is least effective if the patient has close to normal flexibility. So if they're close to normal, we don't really use this, but if it's quite limiting, this is something that you want to use. The last one is hold, relax with hold, relax with agonist contraction. This is a combo of the first two. So this combines hold, relax, and contract, relax procedures. So first you will move the target muscle. You'll get that, right? You'll get that target muscle identified, and you will move the limb to the point that tissue resistance is felt in that identified range-limiting target muscle. The patient performs a resisted pre-stretch isometric contraction of the range-limiting muscle, then followed by voluntary relaxation of that muscle and an immediate concentric contraction of the muscle opposite. So again, if we use biceps, triceps, I'm going to lengthen the biceps to the point where it's got some tension in it. I'm going to hold it for 30 seconds. I'm then going to have them contract biceps for that 5 to 10 seconds with an isometric contraction. And then the moment that they let that go after that 5 to 10 seconds, we would passively move that arm into the new range, but at the same time, we would ask the patient to contract the triceps along with us. Biceps is the target muscle. We lengthen it, shorten it slightly, ask them to isometrically contract, and then we would move into the new range. Along with us passively moving it, we would also then ask the patient to concentrically contract the triceps, thus lengthening it. Same precautions for this is the same as hold, relax, and agonist contract. Thanks, that's the end of the slides. Have a good rest of the week. This will not be on the quiz this week, but it's certainly some of this material will be on the final exam. Thanks again.